Our next speaker is Elizabeth Anderson. Elizabeth is a registered respiratory therapist, also holding a bachelor's degree in respiratory care and a master's in business administration. She is now working for RRT. Her talk today is on home ventilation, the transition from hospital to care. Her talk is being sponsored by RRT.
Hi, everyone. I'm Elizabeth. And like she said, I'm a registered respiratory therapist for AeroCare. Today, we're just going to talk a little bit about the home ventilation and kind of the non-invasive side of things that you don't really get to talk a whole lot about or hear a whole lot about when you work in the hospital setting. So I'm going to share my screen. All right. New slideshow. Okay, there we go. All right, so first of all, kind of our objectives that we're going to talk about, or I'm going to talk about, some of the challenges to a safe transition into the home care or into the home when you discharge from the hospital. The differences between non-invasive ventilation in the hospital versus non-invasive ventilation in the home, and non-invasive interface options, and then I'm going to share some patient success stories. So some of the biggest issues that we run into being in the home care world is housing issues. And that means anything from like homelessness to having an unsafe living environment. I'm sure a lot of you out there have heard the horror stories about, you know, bug infestations, lack of plumbing, you know, all the just the dilapidated homes that you might have to go to when you work in the home care world. And of course, the unsanitary living conditions. And those are some of the biggest housing issues we run into. You also run into the issue of having the availability of caregivers to kind of help care for these elderly populations that we see more of in the home care world. So individuals who require assistance in completing their ADLs and adhering to their healthcare routine, they don't always have the support that they need. And this is especially prevalent in the elderly population. We also run into a lot of vision and hearing impairments. And of course, that impacts the ability to safely operate some equipment. Some patients with intellectual disabilities, they might have trouble understanding why they need to adhere to their home therapy. And of course, that creates problems with compliance and readmissions. And then of course, a language barrier, and then cultural differences. Because throughout different cultures, the way that a person views their health and the importance of it, it's different throughout different cultures. So what are the goals of non-invasive ventilation? Of course, it's to maintain the patient's CO2 within a good, safe range, to improve the patient's quality of life, improve chronic lung disease management, and improve the patient's ability to perform their ADLs. So in the hospital, we more often than not use BiPAP ST as a non-invasive way to manage their CO2. And that's great and everything, but that also requires the close monitoring of a clinician to make sure adequate ventilatory support is being delivered to the patient. In the home world, we use mainly 3 different modes that we use. There's volume assured pressure support, mainly as a nighttime mode, pressure support as a daytime mode, and then pressure control also as a daytime mode. So of course, BiPAP ST, it triggers to IPAP on the patient inspiratory effort, but in spontaneous time mode, a backup rate is also set for patients to receive a minimum number of breaths if they fail to breathe spontaneously. So of course, this is beneficial because it's a great non-invasive option for patients requiring management of respiratory failure in the hospital setting. Some of its downfalls are that it requires close monitoring from the clinician to assure an appropriate tidal volume is being delivered to the patient. It requires the clinician to maintain the appropriate settings to, again, assure the adequate ventilatory support. And it does not adjust pressure based on the patient ventilatory status. That's something that has to manually be done by the clinician. So the types of home ventilators that we typically use are the Respironics Trilogy, which is probably the most common throughout the home care world, the ResMed Astral, and the Brios Vivo. So volume assured pressure support is one of the forms of non-invasive ventilation that uses automated algorithms to adjust pressure support and deliver an appropriate preset target ventilation to stabilize the PaCO2 over several breaths. So on the Trilogy, it's referred to as AVAPS, and on the Astral, it's referred to as IVAPS. And I don't know about anybody else, but when I worked in the hospital, we typically didn't see these modes, even though we had the equipment that was capable of doing it, we just didn't utilize these modes. So what happens in these modes is the clinician sets a targeted tidal volume for the patient based on their ideal body weight. And then the clinician then titrates a pressure support minimum and a pressure support maximum based on the patient's tidal volume and their respiratory rate and all sorts of their other breathing mechanics. So, and then what the ventilator does is it automatically adjusts the pressure support within the set range based on the patient's exhaled tidal volume and minute volume. So some of the benefits of volume assured pressure support include it does not require constant monitoring from a clinician to assure the appropriate ventilatory support. We've got remote monitoring capabilities, so that lets us look at things like compliance and if their pressure is adequate or all sorts of different mechanics of their breathing, if you will. And then we can also kind of synchronize their settings to be a little bit more comfortable for the patient. We can adjust things like their rise time, their eye time, their trigger cycle, the things that we call comfort settings. So pressure support, again, is often a daytime mode that's used. What it does is it augments tidal volume. And we use it non-invasively with either nasal pillows or a mouthpiece. It's for spontaneously breathing patients only. And it's an ideal daytime mode to assist patients in completing their ADLs. Pressure assist control ventilation is another non-invasive option we can use. We typically just use it with the mouthpiece. And that's ideal for recovery after exertion. And then it's also an ideal mode for daytime ventilation in people with neuromuscular disease. So some of the disease processes that we treat with non-invasive ventilation is stable hypercapnic COPD, obesity hypoventilation syndrome, and kyphoscoliosis. So VAPS has been proven safe and reliable, or has been proven safe and reliable in the management of stable hypercapnic patients. It's a more favorable treatment strategy compared to the non-invasive fixed inspiratory support, as the patients perceive a better sleep efficiency and quality of life. So in obesity hypoventilation syndrome, not only is AVAPS as competent as the BPV-ST modality of non-invasive ventilation in improving oxygenation, let's see here, and health-related quality of life, but it also has the added advantage of decreasing the patient's CO2 efficiently. So AVAPS in kyphoscoliosis has been associated with significant improvement in ABGs, vital capacity of patients with kyphoscoliosis-related chronic respiratory failure. It's also accepted by the patients, resulting in a good patient compliance and an effective treatment plan option. So there are contraindications to NIV. Some of the biggest ones I've got listed here. They include respiratory arrest, cardiac arrest, hemodynamic compromise, and unstable arrhythmias, facial trauma, surgery, and burns, especially to the facial area, a blockage of the upper airway, an impaired cough reflex or swallowing. So essentially you can't protect your airway, gastrointestinal bleeding, and severe encephalopathy. So some of the interfaces we use include a full face mask, a nasal mask, or nasal pillows with a halo chin strap, and mouthpiece. So the full face mask, it covers both the mouth and the nose, and it provides relief for mouth breathers. It's more comfortable for people with nasal obstruction, and then it performs better for those with higher pressure settings. So one of the downfalls is the added weight of material can be uncomfortable for some users. So the nasal mask interface, it sits over the nose and against the cheeks. It's a more comfortable delivery method for the pressure. And it also has more choices for shapes that fit differently on the face. So some of the downfalls include chance of broken seal due to mouth breathing, discomfort for those with frequent allergies or sinus infections, and difficulty breathing for those with enlarged turbinates, narrow nasal passages, or a deviated septum. So with nasal pillows, they sit at the opening to the nostrils and they're held in place by a smaller headgear. It's more tolerable for those with claustrophobia. It's secure, fit for restless sleepers and those with heavy facial hair. Some of the downfalls, again, discomfort for those with higher pressures, nasal dryness and nosebleeds, and you can lose the seal due to mouth breathing. So, and then with the mouthpiece interface, some of the benefits are it's easily removable from the patient mouth. It's ideal for those with claustrophobia who cannot tolerate material touching their face. It's an ideal mode for recovery after exertion or even with exertion. And it's an ideal daytime mode in persons with neuromuscular diseases. So now I'm going to get to some of the success stories that we've seen with non-invasive ventilation. I do want to point out that I did obtain consent from this patient to share her story. But her name is Ani. She is a pediatric patient who has muscular dystrophy. She uses mouthpiece ventilation during the day with volume assured pressure support at night. Her non-invasive ventilation has really given her more quality of life, and it's delayed her from needing a tracheostomy. It also allows her to participate in swim therapy, which is some of the only movement that she gets with her muscular dystrophy. Our next success story, we'll just call him patient number 2. So before non-invasive ventilation, he could barely leave his bedroom without having shortness of breath. He couldn't make it to his front door without having to stop to catch his breath. And he required assistance in completing his ADLs. So since he started a non-invasive ventilation, he's able to complete his ADLs with ease. His O2 requirement isn't as high, and he's able to work in his yard, which is something that he's really enjoyed. And then with patient number 3, before NIV, she never left her couch, and she had trouble just walking around her home. So with NIV, she got to the point where she was able to walk a mile, and she was able to cook her own meals. So it's kind of the littlest things that we take for granted that really makes a world of difference for these patients who use non-invasive ventilation. So, and then here are just my references that I used. So, and that's all that I've got as far as non-invasive ventilation goes in the home world. So we'll open it up for questions.
Yes, Elizabeth, thank you very much. That was very informative. We did have one question, and a gentleman asked it was a lady, excuse me, what units are you primarily using?
So we have, in the past, we primarily used the ResMed Astral, but Respironics, of course, has come out with their Trilogy Evo, and we're seeing a lot of benefit with the patients that are using the Trilogy Evo. Some of the same benefits clinically as we saw with the Astral, and the great thing about the Evo is that it's still patient friendly, and the patient can operate it a little bit easier than the Astral. So we've kind of made a switch from Astral to Trilogy Evo.
Awesome. Thank you, Elizabeth. Are there any more questions? Wait, I think I might see one. Yes. How much success have you had with the VOC SN in the home setting?
We actually, I think we had one patient with the Voxen, and he ended up switching, I think, to an Astral because it was just going to be a little bit easier, a little bit more portable for him to carry. It wasn't as heavy, that sort of thing. But other than that, we've not really used the Voxen.
Okay. I don't have any other questions, but I have one comment, and it's great job, Elizabeth. Very informative.
Thank you.
So thank you. All right, guys, this is it now. We have a long break until 3:45, so come on back and join us.